weekly GECHO sessions. My name is Chris Cassanides, and it's a great pleasure to welcome you all here this afternoon. These sessions are hosted by the Foundation in association with Project ECHO from the University of New Mexico. This afternoon, we have 64 registrations from 14 countries. So it's a great pleasure, actually, to showcase and introduce the subject of MAFLD, the new word for MAFLD, metabolic associated fatty liver disease in sub-Saharan Africa. By showcasing two very important publications that have been available online in Lancet GastroHep from the 9th of September this year. It puts sub-Saharan African on the map. It puts GASA, the Gastroenterology and Hepatology Association of Sub-Saharan, on the map, since these publications were done under the auspices of this association. And it puts the Department of Hepatology at the University of Cape Town and Wendy Spearman with her colleague Mark Sonderup on the map. And it really is a great honor to showcase these two publications. We've asked Mzamo Mbele, a GI fellow at the University, the Witwatersrand Medical School and Wits Donald Gordon Center, to discuss and briefly highlight the essence and substance of these two publications. And then in the second part, we've asked Martin Hale, our resident hepatologist from Wits, to show a couple of cases and perhaps highlight any unique issues that may face a clinician with a patient with fatty liver disease from the pathology point of view. So over to you, Mzamo, to begin with the two publications.
Good afternoon. Good afternoon, everyone. I'd like to start by thanking the Gastro Foundation of Sub-Saharan Africa for inviting me to present on this forum. I'd also like to thank everyone who's tuned in this afternoon from all over the region as well as the world. It's an honor today for me to be able to present on this new entity, or not so new entity, of MAFLD, particularly within our Sub-Saharan African context. Non-alcoholic fatty liver disease, or as we should be referring to it now, metabolic dysfunction associated fatty liver disease, is the hepatic manifestation of the metabolic syndrome. And it is highly prevalent in even more so in those obese patients as well as type 2 diabetics. Traditionally, it has been defined as a presence of more than 5% steatosis in the absence of any causative factors such as alcohol, various drugs, as well as viruses and other predefined liver disorders. Free fatty acids are the center of the pathogenesis of this disorder, whether they be from the lipolysis of triglycerides from your adipocytes, or from de novo adipogenesis, or de novo lipogenesis rather, from excess triglycerides from one's diet. These, together with a host of other factors, may lead to lipotoxicity via oxidative stress, fibrosis, and subsequent liver damage. It has recently emerged that MAFLD is now the commonest cause of chronic liver disease worldwide, with an estimated prevalence of about 25%, particularly in the Western world. Data about the prevalence and incidence of MAFLD, particularly in Africa, as well as the sub-Saharan African region, are scarce. And the general prevalence has been estimated to be 13.5%. This is likely to be an underestimate, however, due to the increasing burden of non-communicable diseases, particularly the rising prevalence of both obesity as well as type 2 diabetes. Prof. Spearman and colleagues across the region have recently published a series of articles in the recent Lancet Gastroenterology and Hepatology journal And I'd like to give a short summary on some of the salient points with regards to the epidemiology, risk factors, as well as some of the challenges that are faced by our region. As mentioned in a few earlier slides, non-communicable diseases are on the rise in sub-Saharan Africa. The metabolic syndrome has been described to have a prevalence of 11.1 to 23.9%, depending on which definitions are used. Obesity has also increased in the last 40 years or so, with the average BMI increasing from 21 to 23 in males and 21.9 to 24.9 in females, respectively. To go with this, the prevalence of diabetes has also increased over the same period of time. Hypertension is also described in 30% of people, with fewer than half of these patients or people being on antihypertensives, and even fewer having controlled blood pressure. Interestingly, with the increase or the accumulation of metabolic risk factors, so the increase of the odds ratio of not only fatty liver, but moderate to severe fibrosis occurs. The sub-Saharan region comprises of 47 mainly low to middle income countries, with varying economies, varying demographics, as well as gross domestic product. What is common over the region, however, is that there has been an epidemiological transition from infectious epidemics such as HIV and tuberculosis, as well as malaria, to the non-communicable diseases. And the age-adjusted prevalence rates have been described in all the sub-regions as depicted here. So what might be the reason or some of the reasons for the increase in incidence or prevalence? Many factors, including the variability in dietary composition, exercise, lifestyle habits, environmental factors, and genetics may be influencing the burden of fatty liver within our region. The World Bank in 2020 has shown that over the past few decades, there has been a steady increase in urbanization, as well as food insecurity in our region. And this has led to a nutritional transition from the traditional diet composed of high fiber, low fat diet to this calorie dense, sugar dense diet, which accompanies urbanization. Genetics might also account for the high MAFLD or MAFLD prevalence in some populations. However, interestingly, ethnic variation has been shown, and these polymorphisms have been reported with a lower prevalence in people of African descent. When it comes to the management, really the emphasis should be on prevention. Sub-Saharan Africa is or has been shown to be in a unique position to potentially offset the emerging MAFLD burden by leveraging on existing infrastructure and aggressively pursuing more preventative and primary healthcare strategies. General strategies which have shown, or for which evidence has shown to improve or reverse steatosis and liver disease, as well as specific therapies for some of the comorbidities, which have also shown benefit, are there to hopefully avoid the progression to end-stage liver disease and the complicating sequelae that will ensue. There has also been a move towards a new definition of the so-called metabolic dysfunction associated fatty liver disease, and various regions and committees internationally are integrating this definition into their guideline statements. This diagnosis is based now on positive diagnostic criteria that are central to the metabolic syndrome or metabolic dysfunction. And importantly, it does not explicitly exclude alcohol and can coexist with other liver diseases. This definition avoids the stigmatization associated with alcohol and alcohol-associated pathology, and also acknowledges that with the rising prevalence of fatty liver, the causes of liver disease are often multifactorial. Sub-Saharan Africa has shown or has the highest global burden of disease, coming in at 24%. The annual gross domestic product is $1.78 trillion US dollars, and the annual GDP growth on average is 3.2% across the region. However, only 5.08% of this GDP annually is spent on healthcare. Governments, health departments, as well as other international agencies spend the majority of money and resources on the so-called triple threat of communicable diseases in the way of HIV, tuberculosis, and malaria. This panel on the right summarizes nicely some of the issues that are associated with fatty liver disease management in our region, and also includes some of the effects of the current pandemic that have also complicated the issue. Although many comprehensive national guidelines and protocol documents exist throughout the region, the management of non-communicable diseases or the implementation thereof, however, remains inconsistent in sub-Saharan countries. Compounding this issue is the fact that guidance documents for disorders such as your type 2 diabetes, obesity, and others do not include statements for the management of fatty liver disease. So some of the recommendations I picked up from these documents are that we can aim to integrate fatty liver disease management into the current healthcare service. We can also, at the same time, use healthcare innovation, particularly platforms such as this very project GECHO, to allow for the dissemination of information, as well as the empowerment of community healthcare based workers. This will lead to the increase in health education and awareness, and particularly when it does come to awareness, particularly in political and in the public forum, this can lead to the generation of resources to assist us to reach the sustainable development goals, which is primarily to reduce premature mortality by the year, or by a third by the year 2030. MAFLD is an important contributor in mortality and morbidity when it comes to non-communicable diseases in our region. The epidemiological and social transition is leading to an increased burden of disease. And to beat this mostly silent killer, we will require a multidisciplinary cross-sectional approach, which may improve the existing infrastructure, but also lead to new innovation to achieve the realization of the Agenda 2063, which seeks to increase the standard of living, quality of living, as well as the well-being and general health of all the African citizenry. Thank you very much.
Thanks very much, Nzano. Excellent overview. So tell me, what struck you most about these publications and the issue of MAFLD in sub-Saharan Africa? What was the most striking epidemiological issue?
I think one of the most, the most striking issue for me was the fact that within our region, there's been apologies, sorry, I had some technical issues there. Really has been this change in the epidemiology from our communicable diseases. Although there is a scarcity of data, you can see that there is definitely an increasing and almost a pandemic level when it comes to these non-communicable diseases. And I thought that was quite potent for me.
We have Wendy Spearman. So Wendy, congratulations on two amazing publications. So let's hear your perspective. I mean, how are we going to pick up these patients? I mean, obviously, you know, Zama said we need to integrate in existing infrastructure, but where do you think we might find these patients productively? Where should we target looking for them?
Yes, I think that was really an excellent overview, really covered the main points in those two papers. And I think, as we've shown, the non-communicable diseases are really rapidly rising. And if we look at where the management of that really should be, is at primary healthcare level. So I think we need to identify these patients and identify those who are going to be at risk of developing metabolic dysfunction associated fatty liver disease. So one needs to have an idea. So one needs to have really very simple algorithms that you're able to actually assess these patients, assess what are their risks of developing fibrosis. So really just a simple non-invasive test. I mean, obviously we would like to have the, the FibroScans, but I think simply using the APRI, using the FibScore, using the MAFLD score, one can actually identify those who are potentially at risk of developing fibrosis, and then actually have clear pathways of referral up to secondary or tertiary level. We've shown that in a study from the UK that in fact you can easily identify those patients who were at risk of developing severe disease and refer them upward, and then actually continue management at a primary care level. But I think has been really emphasized is the lack of really sort of understanding that the liver component of the fatty liver of the metabolic syndrome. So none of the guidelines even really mention it in any detail. And I think that's what needs to change. We need to have changing in our guidance documents for a non-communicable disease, so hypertension, diabetes, dyslipidemia, and actually have a very simple algorithm how they're going to manage it. And I think this has to move to the level of primary and secondary level. We as gastroenterologists, physicians, hepatologists are never going to be able to really manage with this rapid rising prevalence of these non-communicable diseases. But I think it's something that is easily done if we just have the right algorithms and education. And these echo clinics, we really need to be looking, sort of expanding them, that we take them to primary care level, which is sort of the ideal for Project ECHO. So these are great, but we kind of speaking to ourselves, we need to look at how we're going to expand that to education at primary care level. Thanks.
Excellent. And Wendy, do you think COVID has been a problem, but do you think it might have opened up opportunities?
I think the main thing with COVID, obviously we're seeing increasing, I think everybody's seeing it, the patients presenting late with non-communicable diseases with target organ damage. But at the same time, we've learned how to use technology. And I think we need to look at that. We've increasingly involved sort of community care workers for, tracing, testing. And I think we need to look at involving that more, looking at the community health workers need to have much greater prominence in our healthcare society. If we look at how countries like Vietnam, Indonesia, China have used community healthcare workers to change the course of viral hepatitis, I think we need to be looking at that for non-communicable diseases. We already have these sort of clubs where patients with hypertension and diabetes are actually meet together, have education programs are run by nursing sisters. And I think we just need to expand that, improve education.
Excellent. Thank you very much and congratulations once again. So the chat forum is open for questions, and if there's anyone who wants to ask a question, you might unmute and introduce yourself. Zama, any other comments? You're fine. You're muted. Okay, well then if that's that, then we'll move over to Martin, who will give us a pathology perspective. And perhaps, Martin, try and give us some ideas on whether there are unique issues from a pathology point of view in sub-Saharan Africa that we should be aware of. So over to you.
Thanks very much, Chris. And once again, thanks very much for asking me to participate in these meetings. Useful interaction, thank you. So what I'm going to do is I'm just going to show you, to begin with, just a bit of a breakdown as to the problems that we have from the point of view of fatty liver disease. So I've just prepared a couple of slides here. Hopefully you should see them. Right, can everybody see that, Chris? Can
yeah, you clear, thank you.
Okay, right. So I think one of the problems that that certainly we have from the point of view of, I think just as practitioners in general, is that, when we talk about fatty liver disease, we automatically sort of make the assumption that's associated with alcohol and diabetes, also called metabolic syndrome. But we tend to forget, in fact, that there's a whole range of pathologies that can initiate fatty liver disease. And Zamo and Wendy have touched on, on metabolic syndrome, and the causes. I mean, we certainly see, most of our patients associated with this metabolic syndrome. But there are a number of other diseases that are characteristically associated. I haven't put these in any specific order of importance, but polycystic ovary, for example, is often associated with fatty liver disease. Sleep apnea, as Mzamo mentioned. Dermatological conditions such as acanthosis nigricans can also cause fatty liver disease. A very important cause, and we tend to overlook this, and that is the therapeutic agents that we use. For example, drugs such as antiretrovirals. We have a very high number of patients or on antiretrovirals, estrogen therapy and other steroid therapy, testosterone as well. Chemotherapy, we tend to forget about chemotherapy as a potential cause for fatty liver injury. Amiodarone pops up from time to time. Many of our patients are on that. And then, of course, there is this old drug, Parenchymal that seems to be making a comeback. I'm not so sure that it's making a comeback here in South Africa, but certainly it's being increasingly used in places like the United States and Europe. And remember as well that not all drugs that patients consume are necessarily prescribed, but you've also got patients who use cocaine and so on. That can all cause fatty liver injury. So the message that I'm really trying to get across is that one, certainly from a pathological point of view, shouldn't just automatically assume that fatty liver injury is due to the metabolic syndrome or alcohol. And then other viral causes, hepatitis B and C, both of those viruses can cause fatty liver disease. And specifically, in fact, hepatitis C is renowned for causing fatty infiltration of the liver. And when you're faced with the lymphocytic infiltrate in the portal tracts and you see a little bit of fat, it's very tempting to say that it's fatty liver disease without asking the question, has this patient got hepatitis C infection? We don't see much hepatitis C down here, although it is increasing in frequency in South Africa. And then, of course, you've got the other complications, nutritional complications, bypass surgery, malnutrition, particularly in our infant or pediatric population, and then parenteral nutrition. Inborn errors, Wilson's is one that comes to mind. Wilson's disease in the face of an unexplained chronic hepatitis with a bit of fat and nuclear clearing or glycogenation. One of the first things that one should think of to exclude is the possibility of Wilson's disease. It's one of these diseases, if you don't think of it, you don't get it. And then, of course, rarer deficiencies such as galactosemia. And then, of course, those patients who have deficiencies in lipoproteins, because lipoproteins, as we know, play a vital role in the transport of fat through the liver. Parenchymal necrosis, and here we need to think of any cause. Hydrocarbons come to mind, and then, of course, the toxins such as mushroom poisoning and so on. And I think just to touch a little bit more on parenchymal necrosis, I think it's important to recommend that one of the reasons, at least to identify, one of the reasons why you get fat in the liver with parenchymal necrosis is because of the dysfunction of the hepatocyte. And what happens is that the hepatocyte is no longer able to transport to transport fat in and out of the liver cell. and consequently, you get accumulation of lipid in the hepatocyte. And that comes down to an inability of the hepatocyte to have effective lipoprotein function. Also remember infections. I mean, this list is by no means all inclusive, I mean, from the top to the bottom. But we must remember infections. And I remember as a registrar, one of my mentors in pathology, the late Alan Mills, and some of you will remember Alan. He said that one of the things that you need to think about all the time is that when you get fat in the liver, always just have a look and make sure there's not tuberculosis and in that liver. And in fact, if you go back through the literature, the association of fatty infiltration, anti-B, was described far back as 1944. So we've known about that for a long time. And then other unusual infections that can cause a little bit of fat, Q fever with the classic ring granulometer and so on. So yeah, that's a sort of a range, if you like, of diseases that are associated with fat. So just for completeness now, Mzama has commented on the various abbreviations, and I've listed them there. I've changed it slightly to metabolic associated steatohepatitis. But you know, originally we talked about non-alcoholic fatty liver disease, and then fatty liver disease, steatohepatitis. And then there was a time where this was then further broken up into DISH, CASH, TASH, and so on. And DISH was drug-associated steatohepatitis. CASH is chemotherapy-associated steatohepatitis. And then TASH, toxin-associated steatohepatitis. And as we all know, in fact, this new disease of fatty liver disease was really unknown up until the 1980s. And it was only in the 1980s, in fact, that the first articles started to appear recognizing that fatty liver disease was a burgeoning problem. And as Mzama has correctly pointed out, and Wendy in her article, that this is an increasing problem in sub-Saharan Africa. I've put down here ASH and NASH, and the reason I put that there is because you often find that people who consume large quantities of alcohol, not all of them, because sometimes alcohol is also associated with people in the lower socioeconomic groups, but people who tend to consume larger quantities of alcohol or more than they should often tend to consume higher numbers of calories as well. So often ASH and NASH go together. Right, so let's look then at and then I'll show you a few cases or a couple of cases. So there are a number of scoring systems like histopathology. I mean, all histopathologists like to score things. And that's important from the point of view of grading disease, but also it provides an indication as to whether there is progression of disease or stability of disease. And fatty liver disease is no exception. I personally find grading systems can be quite confusing and in fact taxing. And I think often that I subscribe to the sort of format, if you like, or the belief that less is more. So I'm a particular proponent personally of the Brunt system for grading. I think that it grades things easily. I always say, for example, that personally I find it quite difficult, in fact, to grade things into more than 3 categories. You know, we talk in the old days, we used to talk about, you know, well differentiated, as far as tumors were concerned, well differentiated, moderately differentiated, and poorly differentiated tumors. And I think that that's still, certainly from my own point of view, still pertains, that it's quite difficult to separate these things into more than 3 categories. And I think when that happens, you end up in a situation where you get poor inter-observer variation and poor agreement. So the Brunt system then, I think, is excellent. It, as you see, it was described just over 20 years ago. And the grading system, there's two factors to this. You have the grade, which assesses the extent of the steatosis. And as you can see here, excuse me, the steatosis can be divided or can involve up to 60% of the hepatocytes. But in the mild steatosis, cases with steatosis, there's usually minimal, if any, ballooning degeneration. Lobular inflammation is usually a variable from 1 to 2 foci, and then portal inflammation varies from none to mild. And then it goes right up to grade 3, where you have severe steatosis with marked ballooning degeneration, extensive lobular inflammation, and variable portal inflammation. And this is particularly useful. And you can see here that the grades are identified, and you can see the lobular inflammation. What we do is we assess a number of foci of lobular inflammation per 20 times field. So obviously none is self-explanatory. A score of 1 is given if there are less than 2 foci per 20 times field. 2 to 4, then scores are 3, and 2 to 4 is, I'm just getting a bit lost here. Sorry, 0 is none. 1 is less than 2 foci per 20 times field, and then a score of 2 is 2 to 4, and then a score of 3 is greater than 4. So it's easy to, or relatively easy to implement that. The problem is that often the foci of lobular inflammation are really irregularly distributed through the liver. So you just got to take a bit of a sort of helicopter view, if you like, and give it an assessment. So having assessed the grade, the next thing to do is to assess the stage of fibrosis. And here, the fibrosis is assessed basically on the Masson trichrome stain. Now here, the Masson trichrome stain, and I'm going to demonstrate this to you. The Masson trichrome is a tricky trichrome stain to develop. It's to do, and it can be quite difficult to interpret if it is not done efficiently and properly differentiated in the lab. So personally, I advocate the use of the Sirius red. I think that's a much easier stain. And certainly in our lab, since we've introduced it here, the assessment of fibrosis is made a lot easier. And certainly I would be very interested in other histopathologists' comments on this. And I know that there are a few of you on the meeting. So what we do then is we look at where the fibrosis is, and the fibrosis in fatty liver disease usually starts off in zone 3. And if the fibrosis is just confined to the perivenular area, then that scores a stage 1. If it extends to include the portal regions, then that moves to stage 2. And then once you get bridging septa, then that moves to stage 3. And then this is a little bit, what's the word I'm looking for? Probably a little bit vague. I think it's better to say, rather than extensive bridging, to rather call that cirrhosis. So that's stage 1 then, when you get minimal perivenular fibrosis, all the way through to stage 4, where you get cirrhosis. And as I said, I've moved away now from the Masson trichrome stain to the Sirius red. So this then is a diagram which demonstrates that. So stage 1, so here you've got the classic triads and the lobular architecture, where you've got the portal tracts in red, and the central veins in red, and the portal tracts in blue, with the 3 structures represented. And here in Brunt stage 1, you get this pericellular fibrosis, sinusoidal fibrosis in around the central veins. In stage 2, what happens is that obviously the retention of the perivenular fibrosis is retained, but you also start to see pericellular fibrosis and fibrosis involving the portal tracts. So that then becomes stage 2. And then stage 3, you start to develop linking between both central veins and portal tracts. You get this bridging, and one sees that there's architectural distortion. And you may say, well, what's the difference between this, for example, and the next stage where you can see that there's complete nodule formation? And I think a useful sort of rule of thumb is that if you are concerned about cirrhosis or architectural distortion, I think as a general rule, if you're unable to move from one portal tract to another without crossing a band of fibrosis, then that will be regarded as cirrhosis. But if you can move from one portal tract to another portal tract without crossing fibrosis, then that probably is architectural distortion. Difficult to assess sometimes on liver biopsies because you haven't got much tissue. But, and certainly sometimes, you know, I would say in a report that, you know, that there is certainly stage 3, but there may be early progression to stage 4. Right, so that's the histology. So now what I'm going to do is I'm going to show you a couple of cases. Right, so in no specific order, but to show you the first patient, I'm not sure if there are any questions before we move to the histology. So Chris, can you see the histology?
Yes, we can see it, Prof.
Great, thanks, Cheryl.
Oh, sorry, Cheryl keeps muting me. Yes, we can, thank you.
So this is a patient who is 48, or she was 48 when, in fact, she still is 48. And she underwent liver transplantation for a combination of fatty liver disease, non-alcoholic, or in fact, combination of ASH and ASH. She had end-stage liver disease, was transplanted in 2019. So she was transplanted a couple of years ago. And anyway, so recently she has had an episode of rapid weight gain. In fact, the BMI is 30. But it was interesting, the comments that were made about COVID. And in fact, what had happened was that during lockdown, this rapid weight gain had taken place. And you can see just on the low power examination that there really is extensive fatty change. Now, when we look at the interpretation of fat in the liver, there are a couple of things that we need to bear in mind. The first thing, and the first thing that's most important, is to separate out what we now call large and small droplet steatosis. Now, let's just spend a little bit of time talking about large and small droplet steatosis. And in the old days, and I still unfortunately lapse into the old way of calling this macrovesicular and microvesicular steatosis. And in fact, that is actually wrong. What we should do now is talk about large droplet and small droplet steatosis. And we should reserve the term microvesicular steatosis for the steatosis that is induced by mitochondrial dysfunction, as for example occurs in fatty liver disease of pregnancy, tetracycline therapy, and so on. So and the reason why we must do that, first of all, we shouldn't perpetuate a confusing terminology, and secondly, to make the clear distinction between what is effectively a life-threatening disease in the form of microvesicular steatosis and small droplet steatosis. Now, microvesicular steatosis, as we know, and we would identify microvesicular steatosis as from a pathological point of view, from the registrars, that sort of thing. What's the difference between microvesicular and small droplet steatosis? Well, microvesicular steatosis, if you look at the individual liver cell, and I don't have any particular, I've seen cases, but nothing with me at the moment. But in microvesicular steatosis, you're unable to count the droplets in the cell. Whereas in small droplet steatosis, you can count the droplets. So that's a very good way of separating out the two. And in microvesicular steatosis, the cell almost has a foamy appearance. So when we look then at this particular liver, we can see that there is a combination of small droplet and large droplet steatosis. And I'm going to see if I can find some small droplets. And I think it's correct to say that small droplet steatosis ultimately progresses to become large droplet steatosis. And in fact, as luck would have it, I can't readily find an example of small droplet steatosis. Doesn't matter, I'll show it to you in the next case. So what we've got then, so the next point is to determine the extent of involvement. In other words, how many hepatocytes are involved by this large droplet steatosis. And it's important to look at the large droplet component. You can ignore the small droplet component because the small droplet component is not really, I have to use my words carefully, it's not really pathological, but recognizing in fact that small droplet steatosis does progress to become large droplet steatosis. But what happens is that when you have large droplet steatosis, ultimately the accumulation of the fat in the cell. So for example, if we look at this here, you can see that we've got this massive hepatocyte here. It is so big, in fact, that you can't see the nucleus anymore. And then ultimately what happens is that ruptures. You get ballooning degeneration of cells. And when that happens, you then get inflammatory mediated injury taking place in the liver. So if we, for example, look at this here, this focus here, you can see that there is this focus here. You've got several cells that are showing this ballooning degeneration. They've collapsed in on themselves, and you've got this lymphocytic inflammation. This is also ballooning degeneration. So this is severe steatohepatitis. And if we look at this, so that's the ×4 lens, or at least 40 times lens. And if we look at this when the picture builds, you can see that we've got these foci of steatohepatitis there, there's some down here, there's some here, there's some here. So in this single 20 times field, we've got at least 4 foci of steatohepatitis. And again, the same sort of thing happening there. Let's move to the portal tracts. And when we have a look at the portal tracts, you can see that you've got portal inflammation, lymphocytic portal inflammation as well. The other point to look at as well is to look at these distribution. And this is not a good case really from that point of view, although it does show that there is panzonal distribution of fat. So if we look, for example, there, so that's a central vein there, that's a portal tract, and you can see that there's panzonal steatosis. So this then is an example then of severe steatohepatitis, and this is front grade 3 at least. Now we're going to look at the degree of fibrosis. So you remember we said that you can only stage it. Let me move to the mass on trichrome. First, because the books say that you must use the mass on trichrome. And I think ultimately what will happen is that people will move. And perhaps I could just ask you to take in your minds a photographic picture of this, because this mass on trichrome, from a collagen point of view, it's not a bad mass. So you can see that this is a portal tract. You can see there's a little bit of septum formation here. And you can see here that that's probably a central vein, and you've got the beginnings of pericellular fibrosis. And that's a good central vein there, where you can see the central, you can see this radial fibrosis. Now, tracts, it's difficult to be absolutely certain as to what we're dealing with. So that's a portal tract there, and you've got this pericellular fibrosis there as well. But if we move to the serious red, you can see that this is much clearer. So that's that same area that I showed you on trichrome. But here you can see far better demonstrated the sinusoidal fibrosis and the pericellular fibrosis that you've got in this. You can see how far it's extending. You can also see in this area there better representation of the collagen deposition associated with the tract, and similarly the fibrosis that's associated with this portal tract. And you can also see another focus here of perivenular fibrosis. So this then, as an example, then we've graded it as a grade 3, and then from a fibrotic point of view, there's another portal tract there, and you can see this radiating fibrosis. So this would be a stage 2. So this would be a grade 3, a stage 2. Are there any questions on that?
Right, thanks, Martin.
I've got another case, Chris.
Let's say just on this case with this massive fatty liver. So now the clinicians faced with fatty liver is very common, even in a general clinical, a general practice, not focusing on hepatology or GI. It's a very common problem. In the absence of steatohepatitis, which we know is a marker of progressive liver disease, is there anything from the pathological point of view that will determine whether the fat that you're seeing in a patient with pure steatosis is going to progress or not? Does the size of the fat droplet, does the distribution, does the amount help you?
So, Chris, that's a difficult question. And I think that if there is no inflammation, then it is unlikely that that there is any liver injury. The problem is if that fat, I mean, first of all, it's the extent of the fat. If it's just perizonal, at least perivenular, without inflammation, and I think one has to establish what the cause of that is. I don't think one should just disregard it. I think from a general practitioner point of view, you need to establish why there is that fat. As has been mentioned, more than 5% fat should be considered abnormal. So you should always look for the potential cause of that, be it metabolic or one of those other diseases. That could it be drug induced as well. I don't think it should be ignored.
Wendy?
So, I mean, one of the problems that we often face now, and particularly patients coming to liver transplant, is this combination of non-alcoholic fatty liver disease and alcohol. And the combination is really a very potent combination for progression to fibrosis and cirrhosis. So if we look at the liver biopsies, and we're trying to sort of establish how much is alcohol, I mean, obviously that's important because we need to address that if we're going to be going on to transplantation in terms of actually recurrence. And even if you don't require transplantation, one needs to actually address alcohol. Do you think things like the Mallory's High Line, neutrophils within the inflammation would help you point towards that alcohol is a significant factor?
So Wendy, yes, I agree with you. And in fact, that's a problem. We face that all the time. And I think that when it comes to the assessment of alcohol, it is tricky. Mallory can be found in patients with kwashiorkor. So they're not unique to alcohol. But if you've got neutrophils are a pretty good indicator that patient has alcohol-associated liver disease. And, I think bearing in mind, of course, drugs, certainly I remember, and I think I may have mentioned on this particular meeting, that when I was a registrar in training, I had a patient who had a liver biopsy, and I showed it to the head of department at that particular time. Also, ironically, one of the experts in liver pathology is one of his specialities, and we agreed that this was alcoholic steatohepatitis. I duly out, and I got a telephone call the next day saying, did I know who this particular person was? I had recently arrived. So I said, no, I didn't. Turned out that the person concerned was a judge. Anyway, so we went into the drug history, and this particular patient was on perhexylene maleate. He had angina. So, that was a very good lesson. The fact that not everything that looks like alcohol is alcohol. So if it looks like alcohol, I think the first thing you have to do is exclude drugs. Amiodarone is also a very potent mimicker of alcoholic steatohepatitis. And I think the other important thing to mention as well is that these patients, these drugs are often, they're on long-term therapy, these patients, and they often forget that they're actually taking it. And, you've really got to delve into that history. But neutrophils, if you've got alcohol and you're concerned about whether the patient is continuing to consume alcohol, the presence of neutrophils are a good indicator.
And just one other comment. Do you think? We seem to think that the pericellular fibrosis seems to be much more marked in those where there's an alcohol component as well. Do you find that? Would you agree? Or
yeah, I would agree with that. Yeah. So the intensity of the fibrosis, particularly if it's periportal, intense periportal fibrosis, lots of neutrophils, Mallory-Denk bodies, that's alcohol. Yeah.
But Mallory-Denk occur in both conditions, alcohol and pure fatty liver.
Yeah, they do. But usually the number of Mallory-Denk bodies is much higher in alcohol.
Okay, Martin, thanks, Wendy. We've got just under, I've got about 6 or 7 minutes, so perhaps we could turn to the second case. No pressure, Martin.
No, that's fine. Right. So let me show you the second patient. Okay, can everybody see that?
Yeah.
So this is an interesting one. Certainly I think it's interesting from the point of view of the discussion that we've had on our Wednesday meetings from time to time. So this patient was or is a 59-year-old woman, and she presented with a history of loss of weight and new onset diabetes. And when she was investigated, she was found to have ANA of 1 in 320 and abnormal function tests. Sonar of the liver showed features suggestive of fatty infiltration. The immunoglobulins weren't raised, and there was no other history of autoimmune disease. Anyway, so she had a liver biopsy, and this is what we found. And you can see, as per the previous case, pretty extensive fatty infiltration. And if we look at at the distribution, and here I think I'll probably be able to find both small and large droplets steatosis. So this is a good example here. So another clue to I think the size of the droplet is that small droplets tend to be no larger than the size of the nucleus. So it's about the same sort of size. And then if you look at this cell here, you can see that this is a hepatocyte, and I think there are 3 droplets. There's one there, there's one there, there's one there. And I think this droplet here and this droplet here belong to this nucleus here. So this is small droplet steatosis, and here you've got large droplet steatosis. The other thing that happens as well with large droplet steatosis, it tends to push the nucleus to the side. And I think the reason for that is purely physical. What happens is that these droplets just ultimately coalesce because there's just so much fat in the cell, and then it just pushes the nucleus to the side. And then as it does so, it indents the nucleus. So she's got mixed small and large droplet steatosis. And I think if we were to assess the extent of this large droplet steatosis, also you really just take a bit of an eyeball and say, well, we've got large droplets there, we've got large droplets there. It's probably about 50%, I would, of the hepatocytes, maybe between 30 and 50% of the hepatocytes. And in fact, when we reported this out, we actually said it was 50 to 60%. So that gives you an idea of the, just sort of literally from a helicopter point of view, looking at it from the top to assess the extent of the fatty infiltration. There are multiple foci of steatohepatitis. In fact, while I'm here, just to point out that there are a couple of plasma cells in this focus here. You can see plasma cells there and there, 2 plasma cells associated with this focus of lobular inflammation. And there's a focus of steatohepatitis. You can see steatohepatitis there. Bit of ballooning degeneration as well that's also taking place in these cells. And then when we look at the mass on trichrome, remember the last one was well done, but this one's a slightly different situation. And here you can see there's quite a lot of counter-staining in the hepatocytes, and it's difficult to assess the extent of the fibrosis. And that's important, failing, in fact, of this particular thing. And really one should repeat it. But if we look at the serious red, you can see that the extent of the fibrosis is much clearer. And here in the central veins, you can see that there is pericellular fibrosis there, whereas the portal vein seems to be the portal tract seems to be relatively clear. And then again, I think more pericellular fibrosis in zone 3 there. Difficult to assess this. You seem to have a portal tract here, and I'm not sure whether this is a continuation of the same portal tract or not. But there is a suspicious area of fibrosis there. Once again, more pericellular fibrosis in zone 3. So this one, ultimately we graded from a grading point of view. We called this grade 2 stage 1 because we didn't think that the portal fibrosis was a significant component. But what is interesting in this was the fact that she had a high ANA. I won't take the time to show you the plasma cells on the H&E because they are tricky to find, but this is a CD38. And CD38 shows plasma cells. It's a good stain for plasma cells. And for example, in this portal tract, you can see that there are several plasma cells in that portal tract. And there is even a suggestion string as well of plasma cells, which we certainly regard with suspicion when we see this sort of thing. And then you've also got those cells, for example, in those foci of lobular inflammation. So ultimately, we decided that this was quiescent. We established that the patient, in fact, had been on immune therapy for a while because of that rate elevated, at least that elevated ANA. And we said that this was probably quiescent, coexistent quiescent autoimmune hepatitis. I think the jury is still out on that. You see there, for example, we've got a couple of plasma cells that are together there. So it raises that this debate is starting to appear in the literature. Is there an association between autoimmune hepatitis and fatty liver disease? So I thought that was an interesting one to thanks, Chris.
Thank you. Any questions? I mean, ANA false positivity, so-called false positivity, is occasionally seen in MAFLD. Wendy?
So, I mean, one of the problems with Wilson's disease, often the histology is indistinguishable from steatohepatitis and autoimmune hepatitis. Would you consider that? I mean, obviously she's got the history of being on immunosuppression. Would that come into your differential?
Wendy, yes, I suppose it should do. Yeah, it should do. Could be a Wilson's. I mean, she is 59, but Wilson's can present at any age, as we know. Good point.
It's one of the histological diagnoses that are quite difficult to make. Yes, we have dry weight copper. And we often miss the diagnosis.
Yeah. No, I think any cause of unexplained chronic hepatitis.
Thanks.
Any other questions? So Martin, just to summarize, unique features in sub-Saharan Africa, clearly we've got to think of TB, we've got to think of HIV and fatty liver, treatment of HIV, I should say. Yes. Anything else that strikes you? Any differences pathologically according to size of droplet or presence of any other? Nothing really.
No, fatty liver is fatty liver, yeah.
Wendy, any final comments?
I think it's been an excellent meeting. Really great to see those biopsies, and congratulations to Uzama on a really very succinct presentation of the two papers. Congratulations.
Right, with that, I think we should close the afternoon session. It remains for me to thank Uzama and Martin very much for their presentations. Thanks to GECHO New Mexico and the India team. Remember that these presentations are all recorded and posted on the Gastro Foundation website. My thanks to Cheryl, too, for fantastic background organization with all these meetings, and also to our sponsors. Our meeting next week is devoted to PBM, patient blood management, and I look forward to seeing you next week. So from all of us at the GECHO team, goodbye, good afternoon, and thank you for attending.